So I too have thoroughly enjoyed these last couple of days. So my first thought is I'm supposed to sort of round this out as a clinician, and also I'm going to add a few comments that I think go to the whole DRI process as well. But the first thing to say is I have really reveled in the presentations. I feel like I have seen my whole career of training through practice to hoping we do some durable good someday. So just the fact that we're all here together, and really applaud the Academy and the strength of convening, because one of the things, I know not everybody in the room has spent much of their lives working through these processes, but the fact that we're together will anchor things going forward. So that's terribly exciting. Then really, and when Gary was here, I will quote him, the issue of how do we feel as clinicians is we really don't have any information. We are hamstrung. The pressure you feel when you're sitting across from a patient to make an, if you will, evidence-based decision, something other than what you think or what's happened, and I in no way take away from clinical experience. And especially these days when many of us are at teaching hospitals, and part of our job is to train the next generation of physicians and of nutritionists and speech therapists, all of these people that swirl around. And today the expectation is what we teach should be evidence-based. So we are constantly in a problem where we don't have the kind of evidence that we would like. And as Gary said, you know, you sit there and you go, I'm not sure what to say, and yet we're a wealth of knowledge to some degree. So that goes on really to clinical judgment certainly has to be a part of this now. In the same hands, even though we don't have the best evidence, we have to make clinical guidelines. We have to use the process that you saw. We have to use the best available evidence. We cannot remain silent as clinicians and members of the society who feel like we do have the responsibility to keep moving the field forward. On the other hand, we're completely in contrast to the other part of what's going on here. The DRI, the Dietary Guidelines for Americans and the DRI systems, until recently have been able to pretty much remain silent on some of these chronic disease issues. And you've probably picked up that that has changed, particularly for the DRI process, which anchors all of the federal programs. So the DRIs help inform the Dietary Guidelines for Americans. The DRIs are what help us figure out what we're going to put in the WIC program or in school lunch and all of that. So don't underestimate the importance now of, you know, all those figures you've seen 10 times and the U-shaped curves. There's another element of that will be asking every group to say, is there an opportunity to make a DRI, which means for a specific nutrient, for a specific chronic disease. That door had never really been opened before with that kind of specificity. And one of the things that's happening right now, you may have heard a comment or two about this, but the DRI for sodium and potassium is currently under review. And it will be going on for another year or so, so this is not something that's coming out in May, although I really look forward to the new cancer report. But this is a real life experiment of trying to use all of this in this process. So clinical judgment is what we have. We have some evidence. We have to make clinical practice guidelines. We have to train the next generation of people to provide care. We were schooled in believing that the RCT was like the God of everything. And again, it's been very interesting and I think appropriate as we think about that isn't always the possibility and certainly not in our setting. And how do we contrast that with the new stuff of really thinking about an N of one trial or a multiple exposure kind of experience when it's safe, and that might be really good for some of these. The other thing that our academics has really permeated the learning environment and maybe the care environment is now people at a different level of training actually know what the grade of evidence is, and they're going to sit there and argue with you. Well, I'm not sure we should be doing that. It only has a moderate grade of evidence versus a high grade of evidence. There are not many things in clinical medicine, probably other than, treating strep throat with penicillin, that has a really, really high grade of evidence. I'm being facetious, but you know what I mean. It's not really often what we have at hand. So one of the big issues for us is how to take all of this, our standards of looking at things, and bring it back to real clinical care. The only other couple of things, so that part about as physicians and nutritionists, we can't remain silent. We have to have these interactions, but how do we do that honestly? And how do we do that with doing no harm? The other big part, just to mention, I feel like the issue of what is a chronic disease is also part of an evolution. And again, those of us who've worked in DRIs and recommendations, there's always been the tagline that this is about healthy people, right? It's the dietary guidelines for healthy people in the US. It's the RDAs for healthy people. But we're now in a setting where over 50% of the adult population has a chronic disease. And if you add up obesity and hypertension, maybe high risk for cardiovascular disease, there are not many of us left over here after you're 30 in this healthy people. So that whole paradigm is something I think we really do have to work on, which is, again, the benefit of us now being able to think in this whole institutional framework about what could we say about chronic disease. So what's going to be the first 2 or 3 or 4 successful chronic diseases, or diseases for which we can come up with an evidence-based recommendation. The issue of nutrition, and as a clinician and as a scientist, when am I talking about nutrition to prevent a disease? And there might be a handful. When am I talking about nutrition as sort of helping to cure a disease? And even in things like PKU, where we can lower the phenylalanine, we're not curing the disease. There will be some things, hopefully, that happen with gene therapy and other things that will actually cure some of these. But meanwhile, we're balanced between what can we do to, if you will, prevent the diagnosis, and then what can we do to prevent progression down the road? And where does nutrition play in all of that? And those may be very different things. And I think when we all get to come back and read the summary of this report, I think one of the things that will strike me, and probably many of us, is how many different arrows in that whole long progression, and you can see. And even in given individual diseases, things like sickle cell and the metabolic diseases, how they're going to be a bunch of arrows, because what we did at first did this. And then lastly, I was very struck by our colleague who was speaking on behalf of NADIC and the work done in people in the military. And that really brought back something I haven't thought about as clearly for nutrition, but I think is a real clinical and research opportunity, which is the difference between an acute event and what we need versus chronic. And we were talking about in the emergency room. What if we could treat sickle cell pain crises or priapism or acute chest with something in the emergency room that really rapidly improve the care? Most of us don't, nutrition is sort of chronic, it's daily routine exposure. So I think that was another spectacular, it's like little light bulb going off for me, that there are other things that we could be doing. So Barbara, thank you for calling us together. I think it's been a great session. Thank you.